go ahead and start our introductions and updates. And Lori, I think I'm going to start with you.
Hi, good afternoon. I'm Lori Tinker, and I am here via the EMS Council, Trauma Council. Good
to have you here. And thanks for that update about where the other folks are listening to how to get money. And then for the sake, because we have Tedra Cobb here, who's going to be talking to us a little bit later about community conversations, go ahead and just say where you're from and what you do and how you're connected to this table. Dr. Carlbaum?
Sure. David Carlbaum. I'm the medical program director for Jefferson County EMS, which means I supervise the pre-hospital care and training and certification of providers. I have a couple other jobs. My other big time sink job is I'm an ICU physician. So I'm a pulmonary critical care physician at Harvey Medical Center, and I work in the medical ICU and the trauma ICU.
Thank you for being here. Kelly?
Hi, good afternoon. Kelly Parcher, Executive Director of OWL 360, which is an organization that mainly focuses on youth and young adults ages 14 to 25 with housing, programming, supportive services, resource connections, and beyond. Many things happening here.
This community's youth is so lucky Kelly is here. Tedra? You might be on mute.
Muted. I'm Tedra Cobb and I'm muted. Now I'm unmuted. I am a consultant, facilitation, leader, trainer, consultant to UR Medicine, UR being the University of Rochester in New York, UR Medicine in the Recovery Center of Excellence. There are 3 recovery centers. All are funded by HRSA, all focus on rural communities. So UR Medicine is one, UVM or University of Vermont, in Burlington, Vermont, and then the Fletcher Group out of Kentucky. And the Fletcher Group focuses on housing and recovery housing. Could be a tiny house, it could be multi-million-dollar project. So in particular, I work on the community conversations on opioid use disorder and then supporting people who become trained facilitation leaders. And that's what we're going to talk about. Thank you for letting me be here. I'm very excited.
We're happy to have you here. And I should mention that Tedra is in, where are you, Puerto Rico?
I am in Puerto Rico because where I live is very cold and I can't get anywhere anyway. So I just juice up. I'm a Leo. I need to like juice up my heat.
We're a little bit jealous. Matt?
So hi, I'm Matt Reddy. I'm one of the elected public hospital commissioners for Jefferson Healthcare. And we were just talking about this committee yesterday at a big retreat, and I was just like congratulating this being one of the strongest, longest standing committees from the original CHIP process. And they were, a lot of the other ones sort of fizzled out, but it's great. And we were talking about hopefully the community health improvement process getting started or happening again with a community health needs assessment, and hoping there were some optimistic words about that. Anyways, good to be here. Good to see everyone.
Thank you, Matt. Good to be here. Good to have you here. And thank you for that feedback. We feel very lucky that all of you guys continue to come back to these meetings. Jim Novelli.
Jim Novelli, CEO at Discovery Behavioral Healthcare, Community Mental Health Center. And I'm going to be quiet today because I'm beat up after 3 days in Olympia talking to legislators.
Well, thank you for going there and talking to them. Just for those who have just joined, we are going through with introductions and updates, and I've asked folks to be sure to sort of tell what your connection is and how you happen to be at this table for our guest, Tedra Cobb, who will be speaking to us in a little bit about community conversations. Commissioner Brotherton.
Hello, Greg Brotherton, Jefferson County Commissioner. And one update I'll share, probably everyone knows already, but the cherished crime leader, the ED of OLECAP has resigned. So we're in the second week of kind of transitioning to an interim ED, and we'll be, just keeping the wheels on at OLECAP while we start to look for a new ED and a finance director over there.
Thank you. Thank you. Good to have that update. Chief McKern.
Hi, folks. Timber Kern Quilcene Fire Rescue and the South End Harm Reduction, along with the empowering teams from Quilcene and Brandon. And we're doing lots down here. Actually, we had a huge month for January. We've never had 69 calls and 69 out of 31. And I think Dr. Carlbaum, because that's who we work for, is Dr. Carlbaum. I think our month of January we're having some, I'll call it falls and falls, and there were lots of falls especially with the ice and everything else that happened. So other than that, that's about it.
This is fall season, I guess, for you folks. Anya.
Hi, I'm Anya Callahan, and I work for Jefferson County Public Health, and I help coordinate our syringe service program and do outreach and education around overdose prevention. I'm really excited to see you, Tedra. I was with Lori at the training you did this summer in DC, and just super impressed and really grateful to have you supporting our community.
Thanks, Anya. Brian Richardson.
Hey everybody, Brian from Dove House's Recovery Cafe. Recovery Cafe is a recovery community center, so we ask folks to be drug and alcohol free while they're here. And I was just doing a look back at our numbers as far as members and entries and meal service and stuff goes, and everything's just an upward trend as always. So other than that, I got licensed as a clinical social worker since I saw you guys last. So
Woohoo, congratulations.
Thank you.
Congratulations. Thanks so much for being here today, Brian. Yvonne.
Hi, everyone. My name's Yvonne Owen. I'm with Olympic Community of Health. We are one of the ACHs in the Olympic region. And my role around this body of work is our agency helps support the health serving workforce. And we're also a convener. And so I get to see a lot of you guys when we're doing trainings and things of that nature. So just here to do listening and learning and seeing how I can support everybody.
We're really happy that you're here, Yvonne. And Tedra, just so that you know, Yvonne is the counterpart to the ACH folks that we also happen to be talking to in North Sound, or that you happen to be talking. Yeah. Adam York.
Hello, Adam York from Jefferson Healthcare. I'm a data analyst here. Lots of exciting things going on, but not sure if I have anything BHC related right now. Lots of crazy stuff going on though, trust me. Good stuff.
Well, I'm glad you're anchoring yourself with those drawings that are behind you. Those are really sweet.
Yeah. Yeah. Get those kids into those art classes.
That's awesome.
Come back with all sorts of stuff.
Thank you for being here, Adam. Brian Gleason.
Hi there, Brian Gleason, Jefferson County District Court, one of the behavioral health court team members, also covering for Rebecca. If there's any questions about family therapeutic court and drug court, if I can.
Great, thank you for being here, Brian.
Of course.
Alexis from Believe in Recovery. Maybe I'll come back to Alexis. Judge Mack. Maybe I'll come back to Judge Mack. Lindsay.
Hi, everyone. Lindsay here. And yeah, I coordinate prevention programming in the Port Townsend School District, and I'm based at Jefferson County Public Health. And I guess one update on a personal level I have about myself is that my last day in this position is coming up. I'm expecting a little baby due March 7th, but I'll always have such fond memories of working with you all and rooting for you in a huge way. And I'm confident that the prevention team here at Jefferson County Public Health, is super strong and will be hosting events this spring, like parenting education, med take back events. And yeah, that's all from me.
Oh, that's a lot, Lindsay. We are going to miss you. So happy for what you're moving on to.
Thank you.
Stay in touch with us. We have so appreciated your work. You're so articulate and you're so well at I've watched you with conversations around tables. I'm really impressed with the work that you've brought to this county, and we'll miss you.
Thank you so much, Lori. I deeply appreciate everything you do, everything you all do, and thank you for everything. I am honored to be have been a part of this. Yes.
All right. I think we should send her coupons for baby things. Let's see, who's here from the SBHASO?
Sorry, I didn't get the prompt. I was late. Sorry.
So the prompt is just to sort of give any updates that you have, of course, and then to just sort of anchor, we have Tedra Cobb here, who's going to be talking to us about community conversations. And if you could give her a bit of a sense of how it is you're at this table and what you bring to it connection-wise.
All right. Jolene Cronin, I'm the Administrative Clinical Director with the Salish Behavioral Health Administrative Services Organization. And you may see behind me, this is Heidi Geyer.
Hello.
He is our new sync supervisor for our Salish Youth Network Collaborative Program. And she and I were meeting right before this. We were brought to this table as Salish Behavioral Health Administrative Services Organization is tasked with oversight of the crisis system for Kitsap, Jefferson, and Quitman counties, as well as various state-funded and federally funded programs serving on underinsured or low-income individuals, including a substance abuse and mental health block grant, a criminal justice treatment account, and various other programs like the REAL programs, SYNC, our new program here. We also have a behavioral health housing program that we contract with all 3 counties as well. So that's what brought us to this table.
Thank you so much for being here, Jolene. Let's see. I'm going to go in and try Alexis one more time. Yay!
Hi everyone. I'm Alexis. I'm the executive assistant at Believe in Recovery. And I'm just filling out or I am here today to take notes for Gabby while she's in another meeting. Thank you.
Well, we appreciate you being here on Gabby's behalf. And I should say, for Tedra's sake, Believe in Recovery is a counseling service for substance and recovery community, and she also serves on the drug court, the therapeutic drug court team, and does many other things. She's on the CARES program. She does LEAD program. A lot going on over at Believe in Recovery. Thank you, Alexis, for being here.
Thank you.
And then I'm going to try Judge Mack one more time. I know they were having trouble over there with their connection. Okay, well, he'll come back. In the meantime, let's move on. I want to introduce Tedra Cobb, who, as Anya said, we both saw her out at the HRSA reverse site visit in DC last June or July, I think it was. And July. She was phenomenal. She is phenomenal at facilitating community conversations. And we watched a sample of it. We got to sit with a lot of people and brainstorm about the things that they were doing. And it's not just in, you know, rural communities like ours, but they also have a nice focus on tribe-related work. But we are interested, not only are we interested, I'm going to bring Tedra Cobb in for a series of conversations that we can have in this community. And I really, because this is something that HRSA has given us another year to accomplish, so we've got until August of 2024, I'd really like to see us make a good run at this and take advantage of this resource while it's available to us. And I'm going to turn the program over to Tedra so that she can give you an overview. You'll see in your meeting packet that I've got a couple of slides just to give you an overview of what it is, but she's going to get into the detail. You should feel free to ask all the questions, the easy ones, the tough ones, the cranky ones, whatever you're thinking about when you think about having community conversations. Tedra, please take it away.
All right. So first I want to say thank you so much for letting me be here. And I'm so impressed by your coalition. I live in rural New York. I am not in rural New York right now. I live on the Canadian border. So if you say you're from New York, everyone says I love Manhattan, but I actually live north. And if you say New York, and then people think of Buffalo and all of the snow, I'm 5.5 hours north. Ottawa is the closest city to where I live. So I like to say I travel from rural America to rural America, because that's really what I do, and facilitate the community conversation. So I'll back up a little bit and tell you about how I got here in terms of how the workshop was developed and why it is the way it is. I was asked to create a workshop to address stigma, and I think human beings don't like to be talked at. And I don't personally like the workshops that put people in a room and then say, these are the bad words, use the good words. I don't think that changes hearts and minds. I don't think that helps people to understand that there are different paths in addiction and different paths in recovery. So with that premise in mind, when I was first asked to think about facilitating, I also adopted some artwork from Kentucky. The original grant, the HRSA grant that we had, was actually an Appalachian grant. And so we had an artist at UR Medicine who was really, her specialty was to interview people and then to paint portraits during the interview. So I got portraits of people in recovery along with 2 4-minute videos. So the workshop is actually using and incorporating the artwork and the video to guide the conversation. And one of my colleagues likes to say it's a low stakes conversation. In other words, there's no role playing, nobody's put on the spot, but the idea is that we're all in a room together for 2.5 hours, 3 hours, and we're talking to one another about our experiences. And the other thing about it is to cast the net wide so that there's diversity in the room. Because when we have diversity in the room, diversity of thought, diversity of experience, lived experience, whether it's family member like myself, or whether it's a person in recovery, or I've been a firefighter. I see lots of, hear lots of people from EMS here. So I've been elected, I was a county legislator. So when we have diversity in the room and people start sharing experiences, that's really when the magic happens. So that gives you a little bit of an idea of maybe the mission behind and why we call it a community conversation and not an educational lecture on stigma and why stigma is bad. I think we all know why stigma is bad. And so for the last 2.5 years, I've been traveling around and going to rural communities. Last May, actually, I was on the West Coast for 3 weeks, was in Oregon, and then came up to Washington and was in Grays Harbor, Ilwaco, and then over to Kittitas and Yakima. So we're actually doing that again in June. So when Lori said that we're talking about that, at no cost for you or your network, HRSA funds me to come to you. And so we're working with folks in from Thriving Together in North Central Washington, if I have that right, Thriving Together. So we're sort of looking at putting together a trip where I will be able to come to you and your communities and facilitate the community conversation. I want to add one more thing, and then I'm happy to take a pause and answer questions. I did HIV and AIDS work in the 90s, throughout the 90s. And at that time, there was this idea of one and done. You go into a community and you tell people about how horrible HIV is, and they're going to suddenly change their behavior. We know that that does not work. So when I was first asked to create this workshop, the idea was that I would come and then do the workshop and leave. And I said, nope, what we need to do is do the workshops throughout the community and then do a train the trainer and train people to become facilitation leaders. And beyond that, we need to support people as facilitation leaders. So over the last 2.5 years, we have now 350 trained facilitation leaders around the country. We have monthly office hours, open office hours. People can hop on, they can talk about needs, they can talk about challenges. We learn from each other, and we have quarterly meetings. So it's not really, I am an outsider in your community. I'm just facilitating the first conversation. The magic really happens when you have trained facilitation leaders in your community who then take the conversation deeper and deeper and deeper into the community. So with all of that said, I'm going to pause, and I'm happy to field any questions that you might have, whether they're logistic or philosophical or style, anything that you want to discuss. I'm happy to answer questions.
While people are thinking, I want to ask, in the other communities where you have gone, how many trainings have you done in a county, say, and how do they divide, do they divide it by geography? Do they divide it by different age types or different demographics?
I would say, so when I created the workshop, I tried to make it a half day. So a half day is 2.5 to 3 hours, right? One, in rural America, we're often used to driving 45 minutes, an hour sometimes. So I wanted to make sure that we could do 2 in a day because of people's time and because of distances. So often in a community, I'll do a morning workshop and an afternoon workshop, a morning workshop, afternoon workshop. And then usually at the end of the week, or depending on what the week looks like, midweek, we'll do a train the trainer, and sometimes at the end of the week, a train the trainer. So the answer to that is we can fit in several during a week, several workshops. The other part of that answer is I always say cast the net wide. Sometimes people say, okay, I want you to come in and just do our police officers. The answer to that is no, we don't want to do that. What we want to do is cast the net wide so that police officers might be in the room with counselors, with people in recovery, with school administrators, with parents, so faith leaders. And again, if we cast the net wide and in every workshop, we say, come, here are all the workshops we're offering this week, come to one of them, then the goal is to have diversity in the room, in every room, because that's when we really can learn from one another. I think, I'm not sure if there's anything else I really want to add to that, except that the train the trainer, often in the beginning of the week, I don't know how many people will come to be facilitation leaders at the end of the week, because at the beginning of the week, most people don't know what a train the trainer, what that looks like. So along the week, we're sort of recruiting people to the workshop. And I guess maybe one more thing, Lori, and that is, I never expect that we're going to have 50 people in a room. I'm from a rural place. If we have 12 to 20, that's a win. That is amazing. First off, I just believe whoever's in the room are the right people to be in the room. But I also realize that it's hard in rural places to get people to come. And so when I say, like, I'm just the toe in the door, the work afterwards happens with what you continue to do as facilitation leaders. I hope that answers that.
That was really helpful. I know other folks might have questions. I'm going to add, Greg, go ahead.
Sure, thanks. Really exciting. Happy to have you out here, of course. It sounds just great, no downside. I'm wondering if you can talk a little bit about, I guess, in-person facilitation versus online. It seems like there's a lot of advantages for Zoom, especially for some of our more rural areas, to reduce those barriers. And I'm just wondering if you can talk about, is it a pastiche of, both, or a combination, or one or the other?
Yeah, when I come to the community, it is in person. You are, and I have done a community conversation virtually. We do offer it every now and again, and we've had people from all over the country be able to join. I try to make the Zoom, well, actually, let's put it this way. When we do it virtually, it feels like people are in the room. So I actually have 2 other people facilitating behind the scenes. So I have the tech guy, Steve at UR. I actually am 4.5 hours from Rochester. So I actually have my phone as a hotspot at home. So I go to my friend who has high-speed internet and all of the accoutrement. So you can think about, like, I think deeply about how do we make this happen and make it feel like everyone's participating. So it actually is, when we're doing brainstorming, we put people write in the chat, we cut and paste, and then we put it up as if it's on easel paper, and then we have the conversation. So usually when we do it virtually, my goal is not to have more than 20 people, because I really want people to be talking to one another within the virtual workshop. But when I come to you, it will just be in person.
Do folks have thoughts about where we would like to do this kind of a thing? I mean, I have some thoughts, but I'd like to hear what you're thinking about. When we say cast the net wide, where do we want to cast it over, and where would we anchor that net? Do we want to do it geography, demographically? Dr. Carlbaum?
Yeah, I think, I would obviously turn towards Tedra's wisdom, but I do think involving multiple geographies would be really important, because I think there's a perceived difference between the north end of East Jefferson County and the south end of East Jefferson County. There are some very real differences too, I think, in sort of median household income and other socioeconomic things that create barriers. And so I think that would be important. And I would wonder if it would also be helpful to get a variety of ages. And then I don't know how to really get access, and maybe others here are probably better at this than me, but people that are traditionally unable to use things like Zoom and attend meetings like this, or who are more mindful and aren't great at calendaring because they truly live in the moment, or don't have access to transportation, et cetera. So to make sure that we're capturing people that might have a perspective that is different than what all of us perceive.
So I'm hearing it might be great to include recovery community folks, as well as stakeholders that are sitting at this table, as well as youth, kids under high school, middle school. What do you think? Middle school too young? Too young.
I'm gonna say something a little bit about that, because actually today, a colleague just said that they were working with doing some outreach in West Virginia, and someone said, "Do you have a youth program?" This workshop, I've had youth come with parents, but it isn't a youth prevention. If I were going to be making a workshop, I would actually have videos and interviews with youth and be facilitating that. It would be a little bit different, but I have had kids, teenagers come with parents, and that is amazing. And perspective. I actually, in one workshop, we were talking about trauma, and one of the kids said, "I don't know what trauma is." So we had this conversation just about, it's like, so to me, it's sort of like, okay, let's pause for a minute and talk about what that looks like. I had another young woman whose mother was in recovery, and as the mom was talking, the daughter, I could see it happening. She started getting anxious a little bit, and so for me as a facilitator, it was just like, let's take a minute and give the young girl just a moment to pull herself together, because I could see that as her mom was talking, her anxiety level was going up. So again, this isn't a youth focused workshop. That would look a little bit different if I were going to create one. But I think having youth with parents is pretty powerful, and also talking about what's happening with kids. I want to say something about what you said, Dr. Carlborn, about diversity. I live in a really large county, and there are kind of 5 distinct areas in the county that I live in. And I live in a university town. So there are 2 universities in my community and 2 universities in the town over, but the other communities don't have universities. So I always say, think about things like town and we call it the town and gown. Local people will not go to the university for something. They'll go to the fire department, they'll go to a church, they'll go to the Elks Lodge. Do y'all have Elks Lodges there? They'll go to things like that, but they won't go or feel welcomed at a university. So I expect when I come to you, you're going to make me travel. In other words, my expectation is you're going to say, go here, go there. This is what you're going to do. And I will do what you want, I will be where you want me to be. And I try to make it as easy for you in terms of your planning for me. And we can talk more about the logistics of the workshop and technology needs and things like that. We don't need Wi-Fi, et cetera. But mostly thinking about, as you've said, the barriers that get people, what is difficult for people and where should we hold workshops so that we hit people in the community far and wide.
So the week that we're looking at is June 10th through the 14th. So that means that we'd be having the train the trainer on the 14th, which would be the last day of the time that Tedra would be with us. And the 10th through the 13th, and maybe the morning of the 14th, maybe, we have as space that we could try to schedule some of these. And one of the things that I'm thinking is in some areas, it might be interesting to see if there are meetings that are already happening, groups that are meeting at a community center or whatever, that might be something that we could, because people are already coming for that, we could go to that meeting at an earlier time and pose the idea, would you be open to having a conversation at the meeting that happens between June 10th and 13th of that particular gathering? So that's one thing that I'm thinking about that might help us get some anchor spots going. Are there any other brainstorms, Brian?
Well, I'm happy to offer, the Recovery Cafe as a space in a community and such.
Yeah.
As far as the level of interest of our members, they'll be able to speak to that. But at least putting something out there, we have an opportunity and a community here. So.
Mm-hmm. I was so glad when I saw that you came today, Brian, because I was going to be hitting you up for a location. So I'm glad you got to be here. Other thoughts? And maybe other concerns. Any other concerns? Kelly, I saw you. Kelly, no.
Yeah, I was just going to jump on with Brian for sure. I mean, we're already working on an SUD stigma reducing grant together with many community partners here today. And so we would be happy to offer a space also where there can be some community conversation. Of course, I am here as a representative for the young people in our community. So when we were talking about some young people being trained, I think there are some young people that probably have the skill to be advocates and be trained in their community as a real direction towards prevention, if anything, which is really kind of some of the things that we're trying to offer through our organization. So when we get to that point, if there's the right match, and I don't envision it being much younger than 16, but peer on peer work is super powerful.
Yeah.
Okay.
I want to add something if I could. Oh, unless there are other questions. So I kind of gave you the background of what the workshop looks like right now. When I first started, I was working, like I said, primarily in Appalachia, but very quickly, I started, like you, I started getting requests to go outside of Appalachia. And also, I felt that there really wasn't diversity in the workshop in terms of voices. So one of the things I'm doing this month while I can't travel, and in Puerto Rico, I am working, I'm going through video interviews that we have. So I've been in Nogales, which is on the La Frontera in Mexico. I interviewed folks, I worked there and interviewed folks. So we have some interviews in the queer community, LGBTQ+ community, voices from South Carolina, people of color, some folks in the Indigenous community. I am not Indigenous, but in New York, I've been working with partners to create an Indigenous community conversation, which Lori and I think Anya, that might have been the one that you came to. So I've got interviews. So what I'm doing now is going through, we also have folks who've navigated the emergency departments and talked about that experience, and medical providers. So what I'm doing in the next couple of months as well is taking different voices and putting together a new workshop. So I will be coming to you in June. I'll be facilitating the original workshop. Our mission in the next year and a half is going to be to come out with the new workshop and then to train everybody that is already trained facilitation leaders in the new workshop. So I really want you to know that I'm conscious that that the workshop, sort of the voices that we have within those videos, is not particularly diverse, but we're getting there. And so we're calling it right now CCOUD 2.0, but it will become the community conversation. So I think it's really important to sort of let you know that we're constantly, right now we're really thinking deeply about how we can create this workshop to be more diverse and include more voices, because all of rural America is not the same. We don't all look the same. We don't have this culture. We don't sound the same. It's just different. I mean, I was in Western Oregon, and then I went all the way over to Eastern Oregon.
Very different.
Very different.
Yeah.
Very different.
Uh-huh. Well, I appreciate the awareness and the expansion that you guys are working on, and the fact that we could benefit from that, even, hence another year. Are there other questions on this? Questions for Tedra? All right. Tedra, thank you so much for being here. You are welcome to stay, and you do not have to stay.
I will let you do your work, but I want to say thank you so much. And we've got a lot of lead time here. So thinking about planning, I really appreciate your time and thinking about this and being so welcoming. And I really look forward to being able to work with everybody and meet all the people in your community. It's an honor to be welcomed into communities and be able to facilitate. So I just want to say thank you so much and have a great afternoon.
Bye-bye. We'll see you.
Bye. Thank you.
Okay, moving on through our agenda, there is an updated link for the packet because we got a new one out there, and I'm hoping you all are looking at that. I'm going to put it in the chat here really quickly. Next up on our agenda is the initiatives that are, or the initiative that is going on at the Therapeutic Drug Court. And I've put a link to the updated packet so that you all can see it. And I'm going to share my screen quickly here. And invite Judge Matt to give us a little bit of an overview of what's going on over there at the courts.
Yeah, good afternoon, and sorry about my Zoom snafu there. It's nothing particularly formal that we're doing in our therapeutic drug court, other than just really, taking a strong look at what we've been doing for the last 20 years, how things have evolved. A lot of it's pretty informal, and it really depends on who's participating at the time. And we're really just wanting to make certain that we're utilizing best practices, that we're engaged with our broader communities to support all of our participants. And that's really it. For folks who aren't super familiar with the drug court model, it's, we meet every week for an hour. The team all meets, and then we meet with our participants for an hour, and then they get support throughout the week in their treatment and recovery. And so, we're just kind of looking at formalizing things, and also hopefully evolving them to be as effective and responsive as we can be. So if anybody is, you're always welcome to come observe drug court. It's on Thursdays at 9. And if you have any ideas, we're talking about going to a sort of a national conference in May as a team. It's called All Rise. And yeah, just invite input. Rebecca Marriott's the therapeutic court coordinator, so her email is connected there to the agenda.
Lori Tinker, I see you have a question or a thought.
Just give me a sense of how many folks are in the program, or how many numbers you see.
Right now I just off the top of my head, I'd probably say we have about 20. Our numbers decreased pretty significantly when the Blake case came down from the Supreme Court and all of the controlled substances charges were tossed, and then they've sort of slowly been increasing a little bit.
Okay, thanks.
Other questions? I do get over to the therapeutic drug court, and it is an education. Every time I go, it's an education. So I'd invite you all to come check it out if you haven't been there and seen sort of this aspect of what our system has that interacts with folks in the recovery community. Thank you,
That's
Judge. Go ahead.
That's the Superior Court at what time, Judge?
At 9 o'clock on Thursdays.
Other questions? All right, Judge Back, I know you had to go, so you as well. Stay if you want. Go ahead and go if you need to.
Well, thanks.
All right, we have a host of updates in your package. Let me share my screen again. I wanted folks to be aware that the Board of Health, Dr. Berry had, let's see, I want to say it was, yeah, January 18th. Dr. Berry gave an update on the fentanyl opioid response, sort of thinking and approach and stats that that we're working with here in Jefferson County. And as you may know, Dr. Berry is both public, what is her role? Public Health Information Officer for both Jefferson County and Clallam. I have put a link to the Board of Health meeting video, but I realized this morning that the video actually isn't active, although you can see the agenda and you can see the packet. And then I went in the packet and I realized that all of the slides that she showed that day were not in the packet, but I did screen capture the ones just for her response. So if you'd like to go look at the graphs that she showed, and I don't know if anybody, Dr. Carlbaum, I'm sure you looked closely at this information. Do you have any thoughts or things that you noticed?
Yeah, no, I'm very excited. You know, I think Dr. Berry would like to see how we can get better access to buprenorphine, which is a medication that's treats withdrawal, is a partial agonist for the opioid receptor, and is associated with people using less opioids or no opioids because they also sort of don't work when you use them when you're on buprenorphine. It's usually given in a clinic environment, and I think there's a lot of people exploring what other environments it can be administered in. And I think she's excited. Clallam County is exploring, they've not started yet, but exploring how to have their community paramedics. So they have a program similar to CARES, but a little different, where they have what's called mobile integrated healthcare, or paramedics who do home visits and hospital follow-ups and more sort of clinic work, less emergency work in the field, and having them administer this medication. The city of Seattle is looking at a program similar. City of Tacoma has done one in the past, but abandoned it because it was cost prohibitive and because they were using nurses to do it. And I think she wants to do it in Jefferson County. I'm waiting to have a meeting with her to think about what that would look like. There are still some barriers. I think one of the biggest barriers, as I meet collaboratively with the Northwest Region medical directors, so Clallam, Jefferson, Kitsap, Mason counties, is sort of the follow-up. You know, we just really aren't thrilled to have people start on buprenorphine, but not have a destination of a clinic to follow up in. And I think that system needs to be really robust. I'm super thrilled that under Apple's leadership, Dr. Berry coordinating is thinking about how to improve that system of follow-up, I would assume, so that we can start doing this and think about what that would look like. I do worry sometimes. I worry about the time. So it's still a controlled substance. It's a Schedule III substance. And so it is not in the scope of practice of EMTs to administer. It is in the scope of practice of paramedics to administer, but most days in our county, we have 4 paramedics working. And the pace of administration is sort of giving it when someone's in mild withdrawal, which can be right after they've been rescued, maybe from a poisoning by an opioid. and then waiting 30 minutes and then giving more if they still are in withdrawal, and then waiting another 30 minutes. And so it's sort of committing a paramedic resource to be out of service for an hour at least. And that's a real amount of time. And so I think there's some of these logistical things we need to explore, but I think it's very forward thinking. I think Dr. Berry is very forward thinking. So I don't know. I think it's exciting to think about. You know, I know at the National Association of EMS Physicians meeting held recently, there's a lot of different protocols from different cities. Most still involve transport, either to an alternate facility like a medication assisted treatment clinic or to the emergency department right now. Not sure if there's really a true freestanding model.
Okay.
Hopefully that's what you were asking about.
Yes,
Sorry to talk
yes.
so much.
And then I was going to ask you to lead into the next slide, which has to do with opportunities for intervention.
Yeah. So I saw her data and I was surprised because it looked slightly different than the data that I have pulled, and it was from the Washington State Opioid Dashboard, which is a relatively new State Department of Health dashboard. That I'm still trying to get our data. And I don't know, Apple, if you have Jefferson County specific data. It's censored for me, for the public, and for me. And I've asked as the medical director of EMS to be able to see that data. Their concern is that the numbers are so small that it could be identifiable. But they're still deciding at the state level whether or not I'm sort of permissioned to have that. I've looped back with them several times and haven't heard. So I don't know if Jefferson County Public Health with their new data section is getting opioid response data for Jefferson County.
I can speak very little to it right now. I'm sorry, I'm homesick, so I apologize. I'm not going to turn my camera on. I do believe that the opioid dashboard out of DOH, it is, like you said, it's relatively new. And certainly there's been consensus around the state that many health jurisdictions obviously want to have access to that. It's much more granular data for the county, each county, than we likely have had in the past. In our case, like you said, Dr. Carlbaum, there's a small numbers issue, so that's a little complication. I do know that we've been working out a data sharing agreement through that portal. And I don't know that we've gone live through our new epidemiologists to access that data on any kind of regular basis. It's kind of fresh for us. So I don't want to make a claim here that isn't true without our epis on the call. But I do know they're aware of it. And Dr. Berry may have access in ways that we don't actually have in-house as routinely as she does.
Got it. Got it. Thank you very much. So as I was looking for this and searching, Googling, honestly, Washington State opioid dashboard, I found this other dashboard. And Lori, that's, I think, the slide you're going to show. And it's the state SUDOR, state unintentional drug overdose registry or something. It's a CDC project that has supposedly every state in the country. When I go to the CDC website, I actually can't find Washington State for some reason. But it has some interesting things. And one of the pages they had was sort of circumstances of the opioid overdose. And you can see here, most were, there were bystanders present. And many of them, the fatal overdose was witnessed by people. So people were there when the person used a substance that they didn't know what it was, or a substance that was adulterated or contaminated or were poisoned by something. And this number in the top left, the 68% that Lori circled, is in their estimate the number of poisonings where there could have been an intervention. The other thing that I thought was interesting is the second highest column in this graph is known history of mental health diagnosis. So I think everyone here recognizes the collinearity of mental health diagnosis and seeking medications or choosing to use substances to try to tamp down mental health distress. So it's just a different data set. I think it's interesting. I don't know if the new opioid dashboard is replacing this one, but if you like poking around with data and seeing it sort of sliced and diced in different ways, this might be a resource for you. So I found it really interesting and a different facet of data that I've not seen from the state before.
Very interesting. I'm also interested to know if Jefferson County is in any way contributing to whatever is we're seeing in there. So I'm going to put down as an action item for me to sort of see if I can walk between public health, epidemiology, and Dr. Carlbaum and these sorts of resources, just to see what we can sort of settle on is what's available to us and through which agency. So Apple, if I'll talk with you about how we might do that going forward.
And Laura, I was just going to add, looking at the CDC side of this, just starting to poke around this afternoon. They have buprenorphine dispensing rates by state. They have naloxone dispensing rates by state. Washington's one of the highest. They have opioid dispensing rates. Column County seems in the middle, Jefferson seems in the middle, less than Column. But just some interesting ways to think about different facets of this toxic poisoning pandemic with opioids that we could maybe invest towards.
Mm-hmm. Thank you. I appreciate the, I didn't know anything about this resource, so I was really happy to see it pop up on your radar and get it into everybody else's awareness. Any questions on that before we move on? Okay, our next topic has to do with just funding sustainability for the behavioral health consortium table and some next steps. I am excited to report that just at the end of January, we got in the first 2 years worth of payment through the county and over to Discovery Behavioral Health for the Opioid Abatement Council's funding. And we, so I haven't had time to create a spreadsheet that will show, you know, what money has come in and where it's all going, but by the next time we meet, we'll have that available. In fact, if I get it put together so that we have it even at the end of February, I'll send out a link so that people can see what we've got and sort of where we're spending it month by month. And then I wanted to talk a little, and as one of the things I should say, this 96,329 26.19, it's a little lower than what was here because there's a certain amount that comes off to go to the SBH ASO, I think it's 10%, which they hold on to until I think the end of it. And then if they don't end up spending it in the administering it, it would come back to the county. So that's why the amounts are a little bit different there. Now, you might want to know what we're planning to do with that. I think first off, there is an opportunity for us to do some strategic planning that will inform our actions beyond what we've already got set up and the formalization process that we need to go through in creating a new memorandum of understanding and establishing what governance bylaws, meeting attendance requirements, and any other data sharing agreements that we might want to put together as addendums to that MOU. So there's the process of coming up with these MOUs and developing something that people feel you know, represents what we want to have and sign on to. We need to assess what members we have and need to recruit and where we need to maybe rehydrate members that are on but are not necessarily here on a consistent basis. And then there was, you know, when the county set up for this funding, this piece of the opioid action, opioid abatement funding to come into the Behavioral Health Consortium, one of the things that they really wanted to see was some linkages between what the Behavioral Health Consortium is doing and what the Behavioral Health Advisory Committee that administers the 1/10% is doing. And so that's one of the things that we hope to do here over the next year, between now and the end of 2024. And then another big thing that I need to get done is to build a website. Right now, a lot of what you see is housed on a website that I own, but we want to create something that's specific to the Behavioral Health Consortium so that we know it'll be there, you know, through the next 20 years, and we can put up resources. And then if something happens to me, it's easily transferred to whoever takes over this role in the future. So those are some of the big anchors of what we're going to get done. At this moment, the funding pays for about a little more than a week's worth of my time a month. And so that will be the adjustment that we're making of using my time less and making sure we get exactly what we need to keep the table warm. And then we have these initiatives that we're also looking at doing. Providing leadership planning and coordination is the mandate that comes with the Opioid Abatement Council funding. That's the box that we are there to fill. The pursuit of other funding to do other projects that fit into the mission of this group, that somehow collaboratively or collectively are pursued and the work executed. And we'll tell you in a little bit about one set of funding that we've already applied for here in January. And then, of course, to work through these community conversations in an effort to begin to address stigma. I think that's a big piece of any opioid response. And that's something that I want to have a real solid foundation of here in the first year. Are there any questions about the money, the what we're going to do with it, the what you can expect to see? Thoughts, insights? Thumbs up? Okay. All right. Moving on.
Lori, I had a super
Dr.
quick
Palmer.
question. I'm still learning about this BHAC. If I want to go see what their meetings are about, or like notes or minutes or anything like that, is there a spot I can go or a person I reach out to, or how's that work?
I can see that.
Thank you.
Laura, you've likely tried to explain that in the past. I know it's not always altogether intuitive to everyone. So forgive me for those of you who do know this process, but the BHAC, the Behavioral Health Advisory Committee, was conceived and constructed with a coordinator, and that is Anna McHenry, who is a public health employee. She oversees the BHAC. It did precede the BHC, and the names are quite similar, but that's beside the point. They have different functions, and they have some crossover in terms of folks who sit on both. They have a chair, which is typically one of the county commissioners, and then an advisory committee with folks who are brought in from all different aspects. I'm not actually sure I could name the exact seat names that are on that advisory committee, but in any case, they are growing that committee actually in size. They're actually out eliciting responses for some alternates, as well as other seats to be filled by folks with lived experience. In any case, the Behavioral Health Advisory Committee really was constructed years ago to execute the ability for the county to distribute what's called the 1/10 of 1% sales tax. And that 1/10 of 1% is used to help with treatment and other things related to substance use disorder. So really, Anna is in charge of administering the RFP process that helps community members, community organizations vie for those funds. And managing that is quite a portfolio of work to do. I believe Jefferson County has 16 to 18 vendors. Those are applicants who applied and then they've been accepted and receiving money. And some of those folks are even on this call. And then, you know, we are able to sort of keep that going year over year, and it takes quite a bit of facilitation. But we also want to make sure that as that table, which has been by and large geared to administer the 1/10 of 1% sales tax and to help push that money out into the community for programming and services, as the opioid settlement money comes through the county, as you all are aware, a portion of it is going to this table that we're sitting at right now to help sustain that ongoing. And then a portion of the other settlement is actually being funneled through the BHAC. And they will do the same thing, likely or similar to what they do with 1/10 money. They will set up an RFP process for that funding to be applied for and received by folks who are doing this good work or want to expand on the good work. So just two channels for the opioid settlement funds in our county. That's the way we construed it. And Commissioner Brotherton was a big part of helping conceive that and making it make sense. I appreciate, Laura, you putting in the sort of things that we've got ahead of us. The MOU, or the Memorandum of Understanding, between the BHC and the BHAC is an important paradigm to refresh maybe germinate in a new way around some funding that both tables are receiving and are using in different ways with different areas of expertise, and to sort of cross-pollinate a little differently. So in answer to your question, Dr. Carlbaum, there are minutes. I would say that the minutes for those meetings are actually taken down by a transcriber. So they come a little bit after the meeting. It's a little less immediate in terms of documentation. In the past, that meeting was always in person. Over the pandemic, it went virtual, and now it's back to a blended format. It's held in person at the commissioners' chambers, but also online as well. So you can always visit our site, the public health website for the county, and you can select the Behavioral Health Advisory Committee. It's got its own page within our homepage for public health.
Thank you, Apple. I know too that there's been some challenges with getting meeting recordings and stuff up there. I think the last thing that's on that page is maybe from July. So one of the things that I would be happy to offer is, you know, we could take notes, we could put notes up and host them on where we've got all of the other meeting notes as well, if that is helpful in between times. So just let us know how we can be supportive so that we can have everybody have access to the information from those meetings.
Well, I think it's important for some folks from this table to be at that table and to take their own notes. And I'm sorry if our system with the AV capture, which doesn't work every single time, and also the note taking is a little belated in terms of distributing that. Oftentimes people are not seeing the notes until the next meeting happens, and they're seeing them at the time they've been approved. But I mean, I want this table to know as much as they need to know about the Behavioral Health Advisory Committee, and we certainly want delegates from the BHC to be there as well. But you and I, yeah, exactly. You and I can talk offline about maybe a better synergy for this group to get those notes.
Great, that sounds great. And to go back to the slide where we were talking about the strategic planning session, I wanted to check in with this group. If we tried to set up something perhaps in the fall, is that more viable than trying to do it, you know, in the next couple of months, or to try to do it over the time frame of the summer when we've got a lot of people going on vacation? Okay, if I were to say vote for spring, summer, or fall, where would the vote be for this table about doing any strategic planning, which also could involve the Behavioral Health Advisory? Maybe we have a cross-pollination of that strategic session. I think that might be useful.
I vote fall.
Fall's good.
All right, so I'm going to work on something that's maybe late August to mid-September. All right. Going forward, wanted to give you guys a sense of the grant that we submitted just back at the end of January. Jefferson Healthcare submitted it through their channel, but it's a consortium called the JCPH, Jefferson County's Patient Care Continuum Consortium, which is just a subgroup of the folks that are on at this table. And the funding is about $100,000, and it's specifically to look at coming up with interventions that are focused on the pre-hospital non-transport patients, the MVPs, we call them, multi-visit patients, and the D2Ds, difficult to discharge folks. So we proposed an approach that we would take to do some planning, which would include an assessment, creating a strategic and sustainability plan based on that assessment. And then we would go out and look for more money to support implementation of whatever that plan was. In the budget that we put in for this grant, we've included an amount for a legal compliance expert, because I think that that's a lot of what we have to work out, is how can we talk to each other and where can we share information and where not. And we need somebody who really understands that to help us navigate between all of us how we can do that effectively. This is, and I see your hand, Lori, I'll get to you in just a second. This is the whole effort of going after this particular grant really came out of the work that we did at the data work group with all of the data you folks gave over the last however many years. One of the things that we were clear on is we had started out really wanting to understand how can we ease you know, the heavy toll on resources like the emergency department, you know, the spinning in and out of the jail, the, you know, all of the wear and tear on EMS and our law enforcement teams. But we hadn't really managed to make a big dent in that over the last 3 years. So this is something that's very directed and that sort of takes what we didn't finish with our last grant and tries to pick it up and come up with something really tangible that we can be doing going forward. Lori.
You partially answered it, or maybe I just didn't hear correctly. I was going to ask whether this, the personnel incumbent in this grant was a new hire personnel, or if we would be able to usurp somebody and pay their salary who already exists in some other organization.
So you'll be able to use me for the project director, kind of doing what I did for the last grant, but now for that grant, if we're so lucky as to get it. We have Dr. Carl Baum on there in a sort of pre-hospital space expert advisory. We don't have who it is, but we have the legal compliance advisory expert that we're going to identify if we get the grant. And then data analysis, we'd be using HFPD again. But I think what's really different about this one is Dunya, and I should have said this right at the outset, Dunya, Dr. Carl Baum did a lot of work in laying out what our approach would be on this grant, and having Dunya's insight and input right up front to what we were going to propose to be doing, I think should really help this be an effective approach to trying to come up with some interventions. So with the hospital leading, we'll have at least the eyeballs of Dunya and the awareness. We've got Dr. Carl Baum, whoever our legal compliance, myself to help run point and just, what do they call it? Do some quarterbacking of all of the parts that are going on, and HFPD as our data analysis.
Okay, thanks.
Are there other questions on that? Dr. Carl Baum?
I just want to say thank you for your humility, but really it was Lori that organized the like 85-page grant, putting together all the disparate pieces and making it a cohesive and thoughtful, good read to whoever was reviewing the grant. So thanks, Lori.
I don't know what his bar is for good read, but if you want to sleep, it's a good read. I think that the exciting thing about that was we've got 4 key players that are going to work on that. And even if we don't get this grant, you guys, we've written out a good approach that any funding we can go get, we now have a really solidly thought through project that we can go get funding, and it's something that this community really needs. And sometimes that's the hardest part, to sort of sit down and think about what do we need and how would we go about doing the first phase of it. So good work done here in this last quarter, I feel. I'm moving on to some updates that have to do with harm reduction, and I'm going to turn it over to Anya with a little precursor, which is just to say, you may have seen this slide before where we talked about the Naloxone box installation, and I have never been good enough to make sure that the box that's outside Believe in Recovery, they were the very first folks to put up a box, and I want to acknowledge that and apologize to Gabby that it has not been on some of my slides prior to now. And with that, I'll turn it over to Anya.
Thanks, Lori. Well, as you can see, we've got 5 of the county boxes up that we purchased, and Believe in Recovery's box is up as well. So that's really exciting. We just did a training at Port Townsend Library maybe 2 weeks ago now, and that went really well with their staff, and we're going to have a public training coming up in April. And then we've been working with the county facilities who are in possession of all of the 3 boxes for the community centers. And as far as I know, have been sizing up where they're going to be hung down there. And so last week, Lori and I were down in Brennan at the Brennan Community Center talking to their seniors meeting about the boxes and did a little training with them, and folks are really grateful to be having that resource coming down there. And then in about 2 weeks, we have a training planned at the Tri-Area Community Center, and we'll have one in Quilcene this spring as well. So really grateful for these boxes. Folks are definitely using them. I've restocked most of these locations. I've restocked Recovery Cafe like 3 or 4 times now, restocked the Hadlock Library and the Quilcene Fire Station. So people are definitely utilizing the resource, and really grateful for all the partners and collaborators. We'd love to buy more boxes. We've identified some other communities that have similar boxes and maybe some less expensive means, like designs that we could purchase and potentially have more. So we have some ideas at the bottom there. And if folks have more ideas, please send those to me or Lori so we can add to the list. But it's going really well, and I'm really grateful for the support. And I think it was the right call to move forward with more boxes instead of just the like mechanical vending machine. Any questions about the boxes?
And I want to point out, if you click on the Padlet link, if you happen to have ideas about where you'd like to see one, and just put it in a comment there, we'll collect that up and make sure it gets added to the list of potential places. And actually, anything that you want to say, you can go to that Padlet link and put your comments in there, and I won't even know for sure who said that unless you tell me.
And especially with the more expensive versions of the boxes, like little plexiglass ones, I think like really anywhere you think, wow, this could be here. We could have one in the front room of our office. There's opportunity for that. And we have this pretty much free and unlimited supply of Naloxone from Department of Health that's being refunded. So I'm always happy to help supply the Naloxone supply for those. And as Jolene just said, that our Salish BHASO is purchasing 3 more boxes around the county. So happy to collaborate with them and get those up in locations that are in need of that. And then moving on to the next slide here, I think some of you might know that we purchased a van to grow a mobile service in June, and we've been using that van around Port Townsend since June. We hired another nurse back in October, and we're hiring another harm reduction coordinator, which is what I am, in the next couple months here. And so with those 2 new hires, we're looking to expand mobile services into South County. So hoping to expand presence into Hadlock and Quilcene and Brennan, as well as growing more of a permanent weekly clinic at the Quilcene clinic. So if folks have ideas about places where our van might be welcome in Port Hadlock, Quilcene, and Brennan, please send those my way. We're aware of like the community centers, but maybe if there's a business or a parking lot that that someone might welcome us to. I think for the first month or 2, we're just gonna kind of test some sites and test some different times and see what's working for folks. And then go from there before we make more of a permanent schedule. But I'm really excited to be using the van and to be getting out into South County. We already have folks that come up from Quilcene and Brennan and Hadlock to utilize our drop-in clinic. So to be able to show up there and actually build relationships with people in their own neighborhoods, I think is really important to expanding access. So yeah, once we get those dates and times, I'll make sure to share those with the whole group here, and could always use your help to spread the word about our services, help brainstorm locations, and suggest and collaborate for more outreach events and educational events.
Thanks, Anya. Matt?
Just a quick question. I feel like I should know this, but you mentioned the Naloxone boxes. You just check them and see that you need to restock them. Do we have a record of who's using them, or is it just you just see they're empty?
So at each of those locations, I'm working with someone at the location. So Brian from Recovery Cafe, I've been giving him 40 boxes of Naloxone at a time, and he keeps those behind his desk in a cabinet, and he keeps 8 to 10 stocked in the box at a time. And then when he gets down to like 5 behind his desk, he shoots me an email and is like, hey Anya, can we get more Naloxone? And that's the same with each of those locations. So that's how it's been working. When Chief McKern needs more naloxone, he can shoot me an email and I'll get him, you know, a load of the naloxone in the next couple of days. So at each of these spots, just been working with staff on the ground there and leaders on the ground there to kind of be a point person. And then me or one of my colleagues on my team make sure that we get it there in a timely manner and that they're staying stocked. And we're not like tracking who's taking them. We're tracking the numbers. Like I know how many I've given to Brennan and how many I've given to Recovery Cafe, but I don't know if one person's taking 5 or, you know, the same person's taking it every month. I'm not tracking that. That's, you know, anonymous and confidential, and, you know, whoever takes them, takes them.
Great, thanks.
Other questions on that?
I would rather make you go ahead, Dr. Carlbaum.
No, go ahead, Apple.
I couldn't find my hand feature. I'm not sure where that has gone on the bottom of Zoom. I have a question relative to naloxone distribution. And Anya, I'm looking at you, not putting you on the spot. It's a question for everybody because I'm kind of doing a survey of who's heard about this. So you may have gotten aware through a publication or heard it on NPR in the last few weeks. There's been some spots on it. State Department of Health is putting out this sort of statewide offer to situate kiosks. Now, I can't exactly tell you what the definition of a kiosk is in this case, but they're touting that they have, they're going to be liaisoning with local health jurisdictions to put kiosks around the state that hold 1, COVID tests, 2, possibly naloxone, fentanyl test strips. I mean, they're talking about it like it's a dispensary, but in a unit that stands alone. And they're talking about brokering with local health jurisdictions about that. I'm not at all indicating that we have one or that we need one necessarily. I know we've got a lot of really great stuff going on already. Thank you, Anya, for all of that detail. But I just wondered if anybody had heard about that. I have a meeting with DOH tomorrow to ask them a little more about, you know, where was the memo and who are you including and are we not included as nobody asked us because of X, Y, or Z reason. But I wondered if I could just do a survey here. Has anybody heard about these kiosks that are really dedicated to COVID tests boxes, but will also have other things in them, such as fentanyl? I mean, sorry, such as
Someone emailed Ocean and me about those, and we were like, I don't think we need that. But
yeah, I agree.
Open to learning more about it. I feel like the email that I learned came from like the pharmaceutical company. It wasn't from DOH, but I did hear about those, and I'll look into my emails and I can forward you what I have.
I'm having this meeting with DOH tomorrow about other things, and I have it expressly on the top of the list to kind of just inquire. Like you, I don't know that we need it. We have a really good COVID test distribution system, and we have a good now free naloxone distribution system. So look at us. We're done it ourselves.
Well done, public health. Dr. Carlbaum.
Yeah, I think 2 things. One, I think because of Anya's leadership and us talking about our EMS lead behind naloxone program, the Northwest region, so Column, Jefferson, Kitsap, and Mason applied for a grant from the state of Washington and received it. So we'll be doing a similar program in all counties. And it's like a lot of naloxone. That said, the barrier is still, I think, educating the public that if they need naloxone to like walk up to any EMS vehicle or fire department vehicle and ask. We've also expanded that to the sheriff's office. So I think Tammy Ridgway is working with the sheriff's office so that they'll have more leave behind naloxone. And I just want to say to Matt's question, I believe strongly these should be anonymous, which is a bummer because we don't know who's using the naloxone and what they're using it for. But anecdotally, there's a lot of community naloxone being used for unconscious patients. And sometimes with great success and sometimes not because it's a little too late. But there are people out using naloxone, which I think is very different than 3 years ago. So thanks, Anya, for all your hard work.
Thank you. Okay, speaking of naloxone, there's a new game in town called, do you say it RiVive? RiVive?
RiVive. Yeah, I thought you were going to talk about this, Apple, as soon as you started talking. I was like, that's our next slide. But we're going to, want me to go into this one, Lori?
Sure. Dr. Carlbaum, anybody pitch in.
Cool.
I don't even know how to pronounce it.
So just a heads up for folks, Department of Health, who we get our naloxone supply from, is changing their supplier, distributor, the medication that they get, they're going to start buying this new naloxone called RiVive. The naloxone that we get now, the generic naloxone is a 4 milligram, and the RiVive is a 3 milligram. You can see what the research says, that this is the amount of naloxone that's needed. The more naloxone, the higher doses can make more intense cases of precipitated or acute withdrawal. And that the 3 milligram is like just as effective as the 4 milligram. It has a lower price point. So I think that might have been like the selling ticket for DOH. But we wanted to share this with you because the boxes are going to look different and they're going to be branded different. It's still naloxone, it's the same medication, it's just 3 milligrams instead of 4, but it's just as effective. And RiVive is a nonprofit pharmaceutical company, whatever that means. But
Great. Questions? Moving on. Do you want to talk about this, Anya, or I can?
You can go for it.
Okay, yellow card, the famous, much loved yellow card has been updated. We're just trying to get it printed. The printer now is ordering the paper, which I don't know why that couldn't have happened a week ago. But here we are. I'm really hoping by mid-February, I'm going to reach out to all of you and say, we have the cards, who needs them, generally how many, and we'll get them out. And you'll see that this card has a lot more on it than the last card had. We dropped the logos. We've got hopefully what are really great resources. There is talk the next time around. I love all the celebration. I don't even know how to do that on my Zoom. Our hope is to put a QR code. And once we have a BHC website, for instance, we can have something where even if you call a number and it, for whatever reason, you can hit the QR code and get a current listing, or as current as we've been able to maintain on a website, which might outlast how long all of the numbers are correct on a hard copy. So one of our goals will be to sort of pull out at the different libraries, et cetera, the places that have the old cards and make sure we get these new cards in there as soon as we get them printed. And I want to thank Barb and the folks at the Ground Pounders meeting and the folks at the summit, everybody who contributed to making sure that the numbers on here are the right numbers and that we are able to get it out there sooner rather than later. Moving on from yellow card, South County harm reduction table. We met toward the end of January, and one of the things that we came up with is a recruitment sort of approach that, for instance, when Commissioner Brotherton is attending I think it's the North Hood Canal Chamber of Commerce. Greg, you can go ahead and talk about this if you want. Nope. Okay. Anyways, it's a tool so that we can we have something to talk to when we're talking to people about recruiting for the table. We've seen a drop off of folks who are actually in South County who are attending that meeting. And so we want to go out and refresh our membership because I think it's important, particularly as Anya and Gabby and folks are continuing their efforts to get services down there in South County, that we have a table where folks can come to and we're actually meeting the needs of those folks instead of just guessing at what we think they might need. Questions? Greg?
Yeah, not a question, just to, amplify it. I think this is great. I appreciate the draft that you and Anya put together, and yeah, I'm ready to take it out to schools and the chamber and everything to get more participation. So I think we'll be getting into the skate park foot too. The skate park at their meeting last week had 35, 40 people. So I'm going to add some skating stuff and then we'll be fine.
Oh, great. That's really good. I wonder if we should do a naloxone training at the skate park meeting. Moving on. The BH Summit, one of the things that might have been maybe 2 meetings ago, there was a desire to have a providers crisis resource list. So it's not a list that would go out to everybody in the libraries and that sort of thing. It would just be for providers. We are almost done with collecting all of the content. I think we've got just a few more to go. Then we'll put that together. Our goal is to put it on a 1 page that is folded in half. So you have 4 sides. I'm not sure if we're going to fit everything on there in a font that you can read, but but we're going to make the effort. And on the very front page is going to be sort of the quick hit, the phone numbers or the text and the hours, and then you can dig deeper to see the rest of the broader amount of information we have on each of those crisis resources. So that's in the making. I want to point out, this is something that I'm going to try to do and maybe send out emails or something as we sort of get our BHC anchored, our legs down solidly on the ground. But we have a lot of meetings that go on, and I think that there's a real opportunity to sort of make sure that in one place we have the details of those various meetings, and then ideally I would be able to do some sort of looking across all of the meetings and coming up with some of the, you know, the themes or the important things that it's important for this group to know who doesn't have time to go to every one of these meetings. So where I can, I've put links to the packets and meetings, or I've actually created notes myself so that there would be notes from that meeting, or at least relevant to this group notes. So feel free to come back to this slide as a resource, and it's something I'm going to try to do consistently and maybe get out, have it available on a website as opposed to just in a slide presentation. This is the peer support slide that I always put in. If you've got any folks who are doing peer support, there is a group that provides technical assistance for those folks that our HRSA grant pays for. I've heard they're really good, so I always want to make sure this is available for folks to reach out to. And our next meeting is on Thursday, May 9th, which also happens to be my 60th birthday, so it's going to be a celebratory meeting. And there's an acronym sheet. If you have acronyms you'd like to see me add to this, we'd be happy to get that on there. We are at 4:26. Are there any last thoughts, questions? Happinesses to report that you're getting out 3 minutes early. All right. Well, that's all I've got for everybody. I appreciate you being here today. I'll be coming back to talk to you folks individually about community conversations and planning a strategic retreat. And always ready and willing to hear your feedback about what we could do that would most support the work that we're trying to do at this table. All right, go forth. Have a great evening. Bye-bye.
Thanks, Lori. Thanks, everyone.
Thanks,
Bye,
Lori.
Lindsay. We'll miss you, Lindsay.
I'll miss you so much. But I'll be around. I'll be lurking.